everybody, this is Chris Rusin. In this week's episode, we examine a topic about community hospitals or hospitals that are peripheral to a larger medical center, having to make choices about whether to keep a patient or transfer a patient to the larger hospital in life or death moments. And I have personally been a part of this with a family member. I know from my experience in healthcare that this is a really common problem. Should that smaller hospital keep that patient, or should they get them to the larger hospital that has more resources? We are examining that with Christian Balmer in today's episode. Hope you enjoy the episode. Welcome to the Dare to Be Ready podcast. This is Chris Rusin, and I'm here with my co-producer, James Lipshod, and this is a conversation with Christian Balmer. We're very happy to have you. And where are you joining us from?
From Switzerland, right in the middle of the mountains.
So, Christian, why don't you tell us a readiness challenge that you brought today?
So, my name is Christian Balmer, and my background is anesthesia and critical care. 20 years of experience of clinical work, and have a great interest in simulation too. And so I'm leading now the simulation center that we created about 7 years ago when I came back from Boston, with a main focus on problem solving from the front line, which I think is very, very important to frame simulation. So I live in Switzerland, middle of the mountains, do a lot of skis, and it's very interesting life out here. We have also many challenges. We'll talk about one of the challenges I have here in Switzerland later on.
Great, Christian. Thanks for that introduction. It's exciting that you are both a very experienced anesthesiologist, critical care doctor, and also that you're the leader of a simulation program in your hospital that you have helped build up from its beginnings, and of course has more growth to come. And our organization has simulation in its names, the Center for Medical Simulation. I'm the leader of a team called the CMS Alps team, which we were laughing about because you live in the Alps, but that stands for Applied Learning for Performance and Safety. And our team doesn't only think about simulation, we think about what are all the ways that we can bring learning to healthcare work such that it improves performance in the moment, learning day by day, learning week by week, and so on and so forth, and improves people's experiences over time. Let's proceed with your readiness challenge, because it's a really, really good one. It's a really important one, and you're not alone in it. So I think that the listeners will be excited to think about it with us. So let's do it.
So this is how I would frame it. So the readiness of peripheral hospital with reduced technical facilities to face unexpected high-stakes surgical events. So that would be the main idea. And the reason why I want to talk about that is that I work in a peripheral hospital, and we don't have all the facilities such as ICU, cath labs, or ENT surgeon, vascular surgeon too. And we are about 30 minutes away from the main hospital. Yet we are doing orthopedic surgery, joint surgery, and these surgeries potentially confronted with unexpected surgical events such as massive hemorrhage, cardiac arrest, or loss of airway management, and all these cases, they happen to us. We realized that it was very hard from the peripheral hospital to stabilize the patient, organize the transfer, and communicate with all the different teams that are involved in that kind of transfer. Talking about the surgeons, so the ORA team is one team, but then you have to talk with ambulance, you have to talk with emergency doctors, and you have to contact the main hospital. They might not have the room necessary to take care of your patient too.
Yeah.
and all that creates a huge challenge. Yeah,
So, okay, thank you. So let's recap some of this, and if we have to, we'll go back and go into detail on specific elements. And our goal is to come up with some simple, what we call readiness goals. They're really statements about what we want for readiness. So you have situation, you work in a peripheral hospital. In the US, we might call that a community hospital. And there are different names for these hospitals that are not the big, completely well-equipped hospital in the largest city or in the busiest region. And we have these other hospitals that can be very capable, but they're smaller and they don't have all of the resources of the big hospital. I like the word peripheral as a label. Okay, so about a 30-minute drive. There is a helicopter pad and the possibility of a helicopter as well.
absolutely. Yeah, but with a
Okay.
30-minute drive, it's not worth it. And
Yeah,
we do a lot of mountain savings with helicopters, but for
yeah.
that, I mean, there is no gain.
Okay, gotcha. Um, and you have some resources, but you don't have all of the resources of the large hospital.
Right, right.
Yes, and this is very true in the United States too, and also true in the greater Boston area. There are increasingly more complex surgeries and higher volume of surgeries being done in these peripheral hospitals.
Absolutely. Yeah.
So you have potential for emergency moments, acute events, kind of non-regular, non-typical. I was going to use the word unexpected, but part of what we're going to work towards is expecting these things and being ready for them. Without getting into specifics at your hospital, I know lots of stories from my time in healthcare about this. At Boston Children's Hospital, we had a whole team. They were almost like a special forces team. They actually wore one-piece outfits with the big zipper that goes up the middle and lots of tools on the exterior of the clothing, and they drove in a special vehicle and they would go and rescue. This is the way they viewed it, actually. They would go and rescue patients from a peripheral hospital and bring them back to the main hospital, and they were the transport team. So there's a readiness on both sides of this. There's the readiness of the big hospital to help you transfer a patient, right? And to give you resources. And there's the readiness of your local hospital to stabilize patients, transfer patients if needed. Do you also feel that same way, or how does that feel for you?
Well, absolutely. I think if we have a problem, we need to call and get ready for the transfer. And but the main hospital has to expect, and in some way, the main hospital needs to have some flexibility in being able to accept the case that coming from peripheral areas. Because if they don't, and this is most of the time what happens, you transfer a patient in an ICU that is absolutely full. So that suggests to me that they do not expect that possibilities, and it does happen, and that's something we could work on definitely. So there is absolutely these two paths: the the main hospital and the peripheral hospital, and the idea is that we do share the same way of dealing with those kind of issue because we are both concerned, definitely.
One category that we may not focus on fully today, but let's name it, is that large hospital or the main hospital has a need to be ready to communicate with peripheral hospitals about potential incoming patients and ready to accept those patients and provide optimal care to those patients when they arrive.
I
So,
like it. Yeah. Yeah,
okay,
absolutely. Yeah.
you may or may not have lots of power to influence that, but it could be an interesting project influencing the readiness of the large hospital for these transfers. And then using that same format, what is an area of readiness, one specific thing that we could talk about in the next few minutes that's maybe not perfect in your, it's hard to be perfect, of course, so it's okay that it's not perfect. But what is something that's not perfect around readiness for these moments during surgeries?
I think as a peripheral hospital and knowing that this is possibly happening, we have to be the kings of stabilization and organizing the transfer. And we are not, definitely not. One of the reasons, I mean, there is probably thousands of reasons, but I thought about it very much because that happens to me. we have some team dynamics issues because when this happens, surgeons, emergency doctors, and transfer doctors, and us, we don't share the same understanding and priorities of how do we deal with this kind of patient. And there is a lack of role clarity, definitely. And I've seen doctors um, fighting together because they wanted to prove they were right with a patient in the middle that needed actually care and organized care. And probably because people are not used to work together and they probably don't share the exact same way of doing things or the same idea of how do we transfer the patient from one side to the others, we can get into conflict situation, which is absolutely not the moment to
Yeah.
get into that. And
Yeah.
that is something we definitely need to improve. Um, and that could be a starting point for a readiness plan, definitely.
Yeah, Christian, as you and Chris were talking, I was hearing the potential for a lot of between teams, gray areas, and marginal areas around do we have the same mental model of what this patient needs? Talking about it, the transfer from the peripheral hospital to the larger hospital. If you have a full ICU at this larger hospital and we're in this marginal area where do we even agree that this patient needs to be transported? Now we have this bed pressure issue from the larger hospital that they're saying, actually, we would prefer that you didn't. It seems like a space where some readiness around getting our mental models out there, getting aligned on our mental models of like what is the right care path for this patient. Are they marginal? Could they ever stay? Is there ever a situation where they could stay here? Do they absolutely need to go? When do we hit the big red button that alerts both hospitals like they need to go, they're going now, we're doing this?
Yeah, James, that was really clearly stated. I love your use of the term mental model there, which is, people's sets of rules, and kind of guides what they see and how they see it, and their values and their assumptions are kind of contained in those mental models. But if we don't reveal the mental models to others that we're working with, it can create problems because we've got different mental models across these different types of people, physicians. So if a surgeon has one set of mental models, maybe an emergency room doctor has another set of mental models, the transport team has another set of mental models. And to James's point, if they don't reveal those and make them explicit during these quick thinking sessions and negotiation moments, then it's going to be really problematic, like Christian described. Yeah, James, it makes me think readiness to think together, negotiate, and make an optimized decision in these moments sounds like something that we might recommend to Christian as a focus there.
Yeah, if there's conflict happening over the table with the patient right there, then yeah, it seems like we weren't ready to have those conversations in a hot moment.
Yeah, Christian, so how do you feel about a readiness goal related to that? Very well intended, good people, great professionals, but potentially at odds, having different thoughts about what's best. So readiness to negotiate well and make a quick and best possible decision in those moments.
I buy it.
Okay, you buy that one. Okay. I do remember some conversations about kind of communication and teamwork readiness, and training that people just don't do much of in Switzerland in hospitals, or in your experience. Is that still true?
It's kind of changing. When I came back from Boston, I was presenting something about simulation, and they thought I was presenting something about mathematics. So they had no idea about simulation. And now with the simulation center, this is really getting into the conversation of the directions, and people know that they can count on us and that we can co-create things. So I think things are really evolving, and main topics that we are using is obviously teamwork, communication, conflicts. So when I say communications, we're talking about negotiation things. How do you deal with conflicts? How do you take the leadership? How do you create, maintain, and describe situation awareness? So really important concepts that are new but are getting into the clinical world. And a very important point is that it is also getting into very young doctors. And when we do simulation now with the first year resident, for example, they already know those concepts, which is great because you can work on that. And so there is good evidence that simulation is really coming from the bottom, but going up, and I think people are getting to understand that simulation has to be taken seriously. So it's a good point.
But I love that there are there are regions, countries, and traditions where younger doctors and nurses and others are using simulation more to learn, practice, and prepare, and also thinking about teamwork, communication competencies, relationship building, and relational competencies as they are training. Now, that is fairly rare still, but I'm hearing whispers of that in the wind, and we are some of the people whispering in the wind about that.
We
We
understand.
Yeah, Christian, we have a Portuguese customer and partner called ULS Alto Ave. Portugal's divided into regional healthcare systems, and there was a complete overhaul of the Portuguese healthcare system January 1st, 2024. Total redesign of the system. And they redesigned into regional healthcare systems, and they're called ULSs. And we work with one of those ULSs around Guimarães, Portugal, and amazing people. And we're also starting to work with the universities in that system, and we use a readiness lens. So we're talking to the CESPU University is one of the places that trains nurses and other clinical professionals, and then University of Minho is a regional university there that trains doctors and nurses and others. Anyway, if they use the readiness lens and if they're in communication with the healthcare system, it can influence the curriculum in the medical school and the nursing school such that graduates are coming with teamwork competencies. They're ready to work in a team, actually ready to work in a team, actually have learned a lot and processed a lot and practiced a lot upon arrival at the hospital. And they told me, Chris, you have no idea how different this would be if people are ready in this way. And I said, I think I do have some idea, but yeah, let's do this together. So I don't know how much you collaborate with the universities, or how much you feel the healthcare system collaborates with the universities around readiness.
Uh, it's interesting you asked the question. In fact, I also have a 10% of my time dedicated for collaboration with Geneva University, and
Oh,
we co-created a CRM course using some of the models of the CMS, and we've been doing that for 5 to 6 years, and we can see now that people that are coming to the clinical practice, they are expecting to work that way, which is huge because when they come into stressful situation, they're starting to use um, call for help very quickly, use
yeah.
cognitive aids, try to challenge the authority, but the good way. And we can see that they understand the value of using those tools that we can teach using simulation. And it's clear that this is coming. And another point is that happens in Switzerland too. At the national level, the quality team is asking for hospital to have simulation facilities. And I think that the day when they say, if you don't have that facility, we will not give you the certificate of quality, that is going to be the tipping point, from my point of view, for simulation to be part of the daily work.
Yeah, amazing. Any bridge between the curriculum in the medical school or the nursing school and what the healthcare system really needs, a person like you to represent that bridge is that's what we need. It's incredible. Because right now there's a pretty serious disconnect
Mm.
quite consistently between what schools train people for and what the healthcare system needs. What happens when that unready person arrives at work, is a lot of stress, and it could lead that person. we often think, well, that's a patient safety issue. Yes, of course. And maybe more importantly, it's a psychological health issue for the new employee. And so they will not have good experiences in their new job. They will not be succeeding as much as they could, and they will like it less. They'll have more conflict and maybe leave it sooner. So it's very powerful what you're doing there. Okay, so back to our readiness challenge. So we focused on two things already. One is it's worthwhile to have a project, which is the readiness of the main hospital to communicate well with the peripheral hospital, to expect that there will be some moments of patients coming, to prepare for that, have a process for that, encourage that, be good at that. And then we were just focusing in your hospital about the readiness of this multi-professional team of people who all care a lot to think together, talk together, and make the best possible decision together. Now, these are all good people, but what are the challenges to working across these groups to maybe practice with these groups, create what we would call a readiness plan, this is what we need to be ready for, and then to actually practice together? What do you think the challenges would be, and what are the opportunities?
When you talk to people, when you debrief this kind of situation, as you said, everyone is willing to do the right thing. We got some issues about role clarity, definitely. So that is an opportunity to learn. And how can you clarify that? Then we probably have to sit all together around a table when it's not, the crisis, and make sure that we define um, clearly the same concept. What is safety? What do we expect? And who is doing what? And just put that on the paper. But we co-create that paper to make sure that we all together share the same understanding of that kind of situation. What is the priority at that time? And this is something that definitely needs to be done. And probably the most influential things there is the leadership. I think we definitely need to train leaders, because what happens when we have two groups of different professions, we have two doctors and they tend to stay polite. So it's me, no, it's you, or it's me. And when you don't have a leader, when it's not clear who is the leader, this is a huge confusion thing. And so you can have politeness, which is even worse than conflict, because nothing happens. And when you have conflicts, everything happens, but not for the patient. And it's those two things that needs to be put on the table and make sure that we need to be very explicit and who is going to be the leader at what point of the reanimation. It's not a question of power, it's just a question of efficiency.
Yeah.
And that needs to be absolutely clear so we won't have this discussion or this non-discussion because we stay polite. And this is something we definitely can train.
Yeah, Chris, I'm thinking about these leadership conversations and something like name, claim, aim, and the work that our colleague Lon Setnick is doing with that. Like you
Yeah.
name the situation, claim roles, and aim the team. That seems like sort of a fundamental skill that would be very useful in these situations where it's not clear who's the leader and it's not clear what people's roles are in sort of an emergent situation.
Yeah, James, I love that as a focus, actually. And in the next 5 minutes, we'll try to help. Kristen, you've already thought about these problems deeply, so we'll just try to help you, I don't know, sharpen the edge of some of these ideas. So we talked about the readiness of the big hospital to talk and accept patients. We talked about the readiness goal of your team being more ready to communicate, negotiate, make decisions around transferring patients or keeping patients, where they should be and how they should be treated. And now James has introduced the readiness goal of the team to talk about what's happening in the moment and what's needed in the moment. And that could be true for the leaders. That could be true for the just the clinical team taking care of the patient in the moment and transitioning from them from this is a normal surgery into this is an emergency moment and we need to name it and do the right thing about it.
Right.
I don't know which one of those you want to talk about a bit, and we'll try to come up with a little action plan for you that you like.
You mentioned something which is absolutely very interesting, is when such a case happened during an operation, massive hemorrhage or things. Uh, very rarely the surgeon says, "Hey guys, it's bleeding a lot out here. Uh, how's it on your side?" It looks like the surgeon is doing his things and we are doing our things. So most of the time, it's because we have to increase noradrenaline or volume and pressures, is responding, but it's still going low. Then we're starting to ask questions to the surgeon. The surgeon might not want to be disturbed because he's focused on doing the technical thing. So it's very hard to declare a situation, this tipping point where we are now doing the right thing, or if or we are getting into a crisis. And most of the time there is a ping pong game between those two teams that do not necessarily communicate. And that is something that could definitely be put on the table, and it could be resolved with a readiness plan. Like, how do those two teams doing different things yet um, working on the same patient communicate when things are sliding away, and with the situation awareness where we're thinking that is going to go badly on one side, and the other one says, no, no, I'm mastering the things. How do we share that information at that point before just claiming for that is a crisis?
I'm a huge proponent of focusing on fewer things and trying to master fewer things. It sounds like doing less. We never like to do less, but in my experience, some of it rather hard-earned experience, we make so much more progress when we focus on fewer things. And James brought up this great kind of emergency teamwork framework that our team works on, and Lon Setnick does a lot of great work on. Name, claim, aim. Roughly speaking, name the situation because it's different than it was a minute ago. We have to name it. It has changed. And then claim roles, and then aim people towards the work and do it. And roughly speaking, and apologies to Lon if I got that slightly wrong, but focusing on just the naming
Right.
would be a huge step forward for many teams in many places. Because if we say, this is no longer a surgical patient where we're doing this surgery, this is now a patient that is bleeding badly and needs to be stabilized and resuscitated, or whatever the need is. And again, apologies for me not knowing what I'm talking about in certain ways. So readiness to do that naming, Christian, in two ways. Naming around the potential transport of a patient would be a really valuable skill development exercise among emergency room and surgeons, and just let's name it. Let's name what this is, and that will set us up to make a good decision next. And maybe even claim roles. So we might even say name and claim, because you said we need a leader to facilitate our thinking and our progress here. So maybe name and claim. And in the room with the patient, let's name that the patient's condition has changed. Let's say that the patient is bleeding and that we are no longer doing the surgery. We are doing something different to recover and help the patient. If we name that, like you said, oftentimes the surgeon won't speak. They are tremendously stressed out. They are tremendously focused on stopping the bleeding. They are not conditioned to speak in that moment, as illogical as it may seem. They may even be incapable of speaking in that moment because they are so focused. So how can, as a team, we name what's happening, claim roles, and then do something logical?
It's very, very important, because I saw that very often in simulation, and especially with young people, young residents. It's always a problem to name a situation. But if you use a critical word like cardiac arrest or shock or can't intubate, can't ventilate, like critical word, it is linked to a mental model in people's head, and it all of a sudden align all the brains together. So it makes it completely changed the focus. There's no two teams, but they are just one team around a patient, because when someone says cardiac arrest, everyone knows that we're not doing surgery anymore. We are in a completely different situation. Critical words for critical events are so, so powerful.
Mm.
Yeah, I was thinking the same thing, Christian, that, everyone may have a really strong shared model of what our peripheral hospital is equipped for, but it's about agreeing this situation has now become thing X, massive hemorrhage, that we are not equipped for. And by naming that situation, suddenly everyone's on the same page again. Oh, that means what we're doing now is getting ready for a transport. Because we
Right.
all agree we're not a hospital that does that.
Right. It really fixes the priorities. And if you discuss that, that is the critical word that has to be said. And you already talked about then what is going to be your role because it changed. Then people, they don't have to talk, they know what to do. And that is something extremely powerful if you anticipate that situation before and make sure that everyone knows what he has to do in that new situation.
Yeah, and to give some of the nuance of the name step of that name claim aim, I know that a really skilled version of that looks like what I'm seeing, and I own that this is my perspective and judgment of the situation. What I'm seeing is that we are now in X critical situation. What am I missing? Does anyone on the team see it differently? And
Mm,
that allows other people who may think that we're still in normal surgery to say, to me, I can get this bleeding under control. We're still in normal surgery. Or they may say, actually, yeah, I'm losing control in here. We do need to do that. And it allows them an opportunity if they feel differently to get that out right away and get to negotiation or to avoid that conflict of, the team starting to move towards this, but the surgeon is still in there trying to control this other thing.
So just, I mean, teaching leaders how to create psychological safety to speak up. And I think that's a responsibility for leadership. If they want people of their team to speak up when things go wrong because they have different perspective, they need to invite them for input. And this is absolutely essential.
I love that last thing you said, Christian. As one of our big actions here, let's turn it into a readiness statement, which is we need team leaders to be ready to invite
Right.
the opinions and analysis of the whole team in important moments. And the beauty of these readiness statements is they just make it so clear. Okay, well now we know what our readiness goal is. Every team leader needs to be ready to invite input from the team at important moments, naming moments during a crisis. All right. And so, okay, now we need a readiness program. And this will involve some practice, some simulation. We need to design the curriculum. We need to partner up and make sure everybody designs this practice together. And then let's practice and do it and create that readiness. That's the basic flow that we're talking about. Boy, wow. We did so much. I'm going to attempt to recap. We had the primary readiness challenge of how can a peripheral hospital, so not the main hospital, some distance away from a main hospital, how can that peripheral hospital be ready for what happens when a surgery goes wrong or has a complication and there's an emergency associated with that? Because that peripheral hospital does not have all of the resources of the big hospital. So there's a decision for those teams to make. Can we treat the patient here? Can we stabilize the patient? Do we need to transfer that patient to the big hospital? If so, do that efficiently. The flow of our conversation led us to focus on readiness of people to name what is happening in the moment, which can be a real shortcoming of human beings in general at work, but definitely people working in stressful situations are not good at that. I can say that as a social psychologist, plenty of evidence for that. And so we're looking at readiness of people to name what is happening and then organize themselves efficiently and take efficient action to help out the patient. Whether that's a decision to treat the patient differently in this moment here in this place or get that patient ready for the best possible transfer to another place. Guys, how did I do with that recap? What else would you like to feature as we summarize what we just talked about?
I think also we may add this leadership thing that the leadership people need to understand that if leadership is not explicit, it's not leadership, and also that leaders must create psychological safety and actively seek for inputs of others. so that they can have a bigger view and so that they could increase the team situation awareness. And that is something definitely important from my point of view.
Okay, thanks, Christian. So there is a specific leadership readiness need,
Yeah.
which is leaders of teams need to be ready, or cross-team efforts need to be ready to be explicit and clear and specifically invite input and ideas from the team at important moments. I think we also know there's lots of evidence that just telling people to speak up and even training people to speak up actually doesn't work very well. That leader invitation is the key that unlocks that door to the team doing well. And I'm calling it a team, but the moment you bring two different teams together, like the emergency room and the surgical team, is it a team? Well, it should be forming as a new team,
Right.
but leader of that team, right? So we've got that readiness need to establish those teams and then lead well in the teams. Okay, and Christian, I'm hearing that as your focus and where your brain is at in this moment, which is good and really exciting. So what would you like to work on when you go home? What are you inspired to work on? It doesn't have to be a perfect idea, but what sort of readiness would you like to try to create with your partners back in the hospital?
The first step we definitely have to do is to align our thinking. And my readiness plan was, how can we get ready to create those partnership conversation, collaborative conversation, to make sure that everyone knows what they have to do, that we are clear about when do we press on the red button because there is some implication. And that is definitely the first step we need to work on. That will create a real strong awareness of that can happen to me too. And what are we going to do if this happened to us in a meaningful way? And that we need to talk about that all together with all the teams and make sure we share the same way of thinking through those crises.
Thanks, Christian. Always talk about it. Partnership is the key to making progress along these lines. And, James and I you saw our expressions. We were both excited when you said, I need to bring the people from the different teams together and we need to talk about this and then do work together to solve this. That really is the key. We call it the partnership pathway to creating, lasting change and good programs. And I think that's very exciting. James, as our call to action as we're transitioning here, I'm pretty excited. Christian, thank you so much for your time and attention and good spirit. Loved the conversation. I think you've helped us create a call to action around being aware of how our teams communicate and being aware specifically of leadership influences on how our teams communicate and how our teams perform. And if our leaders are not ready to invite the input of the team, and if they haven't practiced that and worked on that, then when those moments come, the leader likely will not do those things and will not be able to do those things. So listeners, if this has made you think about something that's needed in your environment or your own personal skill set, we'd love to hear from you on that.
Yeah, so folks can always email us at daretobeready@harvardmedsim.org. You can also comment on social media wherever you found this podcast.
Thank you, James. Folks, just to note, many of the ideas in this conversation come from our thinking on readiness planning and the concepts within readiness planning. And there is a free paper out there on readiness planning and how that works and all the mechanisms behind that. And we certainly invite you to download that for free and have a read of it. Christian, thanks again. What's the next fun thing you're going to do in the Alps?
The plan is to go in the mountain tonight and climb one of the mountains and see the sunset tomorrow morning. Sleep outdoor. Pretty cool.
Oh, man. I wish I were joining you to do that. That sounds incredible.